Hi, Happy New Year. This is Alan Lang, publisher of Y'all Politics. It is an honor again for the second time to have a little bit of time with Dr. Thomas Dobbs, who is the Executive Director of the State Department of Health, and talking about a little bit about the latest of what's happening in the coronavirus pandemic. Dr. Dobbs, it's changed a little bit since last time we talked, and I guess it was late July, early August. We were kind of maybe tailing down on the tail end of Delta, and this thing's changed again.
Yeah, well, first off, thanks for having me. And boy, we're still on this roller coaster of COVID, but this one's going to be a little bit different than before. Certainly, we saw, a pretty challenging situation with Delta as far as overwhelming the health system, and also a lot of, sort of avoidable deaths. But we're hopeful that for a host of reasons that the Omicron situation, though challenging, won't have the same sort of severity of effects.
Well, give us just kind of the latest and greatest update. I know kind of the holiday weekend, and as of a few minutes ago, as of when we were recording this, y'all hadn't reported over the weekend. Give us, it was up pretty substantially last week. I think there were 4,000 cases reported on Friday. Give us an update as to kind of like right now what's happening.
We're seeing a lot of transmission right now. Last week, on Friday, we reported over 4,800 cases, which was a lot. It wasn't our single day record, but it was pretty close. I mean, we certainly had a lot of cases. We expect to report a lot today. Don't have the final numbers to present just yet. What we've seen a couple of things. As we've looked at the data, we think we saw basically a post-Thanksgiving sort of holiday surge of Delta variant going into the Christmas sort of time. And so we still have seen some Delta variant. But since that time, we've seen really a predominance of Omicron. Data that we released last week showed that about 2/3 of cases that we identified since the 22nd of December were Omicron cases. Omicron's very different, though. In some ways, it's more worrisome because it's so very contagious. It's more contagious than Delta variant even. We also know that it's not quite as susceptible to the vaccine in the sense that you really need to have a booster to get full protection against Omicron. But we've also been happy to see that the severity of illness so far, whether because it's a combination of the intrinsic properties of the virus, also the underlying immunity in the population, we're just not seeing the same severity of illness that we saw back in the summer.
Yeah, and just kind of from a technical perspective, I think you call the R0 value, which is, I guess, the transmissibility variant. The kind of the original COVID was what, 2 to 3. Delta was more like 7-ish, and now they're saying Omicron's 10. Like one person can, on average, infect 10 people. That this thing is really, really transmissible.
Yeah, no, it is really contagious. And to be honest, if folks don't want to get it, I mean, there's a few things that you need to do. I mean, the best thing to do is get a booster if you haven't had it yet. If you've had a recent booster, data from England and other places shows that, you're mostly protected from getting symptomatic, and you're, very, very protected from severe illness. And so the booster is important. But the same things that worked to prevent transmission previously do work, but there's more chinks in the armor. I mean, you really need to avoid folks more to avoid Omicron. Wearing a better quality mask is going to be important. Airflow. If you go to a restaurant, where you take your mask off, and if you're, seated some distance away from somebody with previous variants, you might not get it. But with this Omicron, because it's so contagious, if there's somebody in the room with it, you're probably going to come in contact with it.
So it's substantially more contagious. It's, I guess, appreciably less deadly on an individual basis. Now, I guess the thought process is that more people are getting it, more people will get Omicron. And if you are immunocompromised or more susceptible, there's just that many more people that on an individualized basis, your statistical chance of having a real major issue with Omicron is substantially lower, but there are just going to be more people dealing with it, and hence hospitalization is going to go up. I mean, is that kind of the math of it?
Yeah, and we're still kind of figuring out what's going to go on with the hospitalizations, because it really looks like some of the sort of pressure we've seen on hospitals in the past few weeks is actually from Delta, from a Delta surge. We actually saw a little bit of a decline in new hospitalizations over the weekend, so hopefully that will continue from COVID. But we'll have to watch that very closely. But even if the risk of hospitalization is low, if you have a lot more cases, obviously you're gonna add to that numerator, that number of new folks going to the hospital. But we do have some new tools coming around the corner, and I think it's important for folks to, especially if you're vulnerable, to understand what those tools are. We have new monoclonal antibody products. We have new oral antiviral medications that are specifically effective against COVID. They're not really available in large amounts yet. So, especially if you're vulnerable, be really careful these next few weeks. I mean, it almost behooves people who are really vulnerable just to stay at home and avoid contact with, most everybody, at least for a week or two, until, this sort of starts to subside and we have better availability of these therapeutics.
And just talk a little bit about kind of the vulnerable. I mean, obviously over 65 is kind of what we focused on, but I mean, there's more to it than that. If you're a smoker, if you're severely obese, if you have heart disease or diabetes, or, I mean, is that kind of the list?
Yeah, and there's going to be a tiering. The people who are absolutely most vulnerable are going to be people who are maybe on cancer treatments, people who are taking medications that make their immune system weak, like if they had an organ transplant, or if you have autoimmune disorders and you're taking medications that sort of suppress your immune system. Those are going to be kind of at our top tier of folks that we worry about. And then older folks, for sure. Older folks are more susceptible to COVID. We know, previously, if you were 65 and older and diagnosed with COVID, there's 11% chance you would die. That's phenomenal. Fortunately, most of our older folks have been vaccinated, and so we do have that level of protection. But even beyond that, yes, you're exactly right. Diabetes is a huge risk factor, cardiovascular disease. Obesity seems to be specifically something that makes COVID so much worse. And so those compilation of factors are very important when we're considering who's at highest risk.
Talk a little bit about, and I think when we talked in the summer, Department of Health and really everybody in the United States pays a lot of attention to reported cases. That's certainly not all the cases that are out there. And when you're comparing country to country, you have different, even from state to state, you have different testing regimes and different testing. I mean, just almost cultural differences that, some, metropolitan area where there's high availability of testing, more people get tested, and there's all sorts of different variables. But in terms of trying to figure out the number, I think the number we were talking about in the summer was like 3x of the 540 some odd thousand people, that there were probably, a million, or at least as of now, I mean, 1.5 million people probably has had either, tested positive or had symptomatic or asymptomatic exposure to one of the, I guess, the three main variants. Is that kind of the math we're working on, 3 or 4x?
Yeah, no, I think that's pretty accurate. Of course, everybody who gets COVID doesn't get tested for it, right? And it's maybe the disease wasn't that severe, or maybe they didn't have access to testing, or maybe they didn't have really, symptoms at all. We do have studies looking at what we call seroprevalence surveys, like people who go they just get blood work. And then we do have, CDC has an accounting of this, of people who have a history of prior infection. It looks like about, maybe about over a third, close to 40% of Mississippians probably have had infection. And if you combine that number of people, and it might be a little bit more than that by now, the number of people who've had natural infection, and then add those who have been vaccinated, and then take out those who've had infection and vaccination, probably 85 to 95% of the state of Mississippi has either had disease or been vaccinated. So
from a public health perspective, if you've got 85 to 95% of people out there who have either had it and or been fully vaccinated from it, I mean, we're beyond the point about talking about preventing people from catching it or being exposed to it, except for the vulnerable, who obviously need to kind of manage their own risk. But I mean, aren't we kind of now just trying to manage the terms of engagement?
Yeah, no, exactly. And I think there was a little bit of a confusing conversation around herd immunity, because we never thought there would be herd immunity to this type of virus. We never talk about herd immunity to flu, right? What we see diminished severity of illness. And so what we have now, fortunately, is we have a lot of people who have some underlying immune response, so that if they get COVID, they won't get that sick. It's time for us to shift our thinking away from a single pandemic to recurrent waves, kind of like we do with flu, right? If you've had your flu shot 3 years ago, we don't think you're protected from flu now. The same sort of thing I think is going to be applying to COVID, which may become seasonal in a way similar to flu, or maybe not quite as predictable, where, you know, if it's been a year from your previous COVID shot, you probably don't really have strong protective immunity. And that's one of the things that's been so important about this booster shot thing coming into Omicron, is it is very helpful. It's not perfect, but, you know, if we're looking at, you know, recent boosters, you know, 70% protective from illness and about 35% protective from shedding virus, we're getting close to more like how a flu vaccine a great flu vaccine would work. But I think we need to be thinking about it more like the flu shot, in that you have to be up to date on your shots to get full protection.
In this past summer, we also talked about the durability of natural immunity from people who had COVID. I'm one of those people. I had COVID literally a year ago today, and so thankfully, pretty passing blow and no major issues. And I got vaccinated thereafter. What you know, and I think maybe the jury, you know, kind of middle of the year was still out. Is there any additional studies with regards to natural immunity, and maybe not as a substitute for vaccination, but somebody who has had natural immunity and, you know, been vaccinated as well? You know, personally, I've made the decision not to have a booster right now, because I've been through it last year, and I got vaccinated in the spring, and I feel like I'm young and reasonably healthy, and that's just kind of the decision that I've made. But what's the prevailing scientific data on natural immunity?
So CDC did a good compilation of all the studies, and it's available for folks to look at. It's a scientific brief, and if you kind of tease it down, you can see pretty clearly that, of course, natural infection does induce useful immunity, but it does wane at the same sort of pace as immunization. So it's not a panacea of, like, you know, you're never going to have to worry about it again. Natural infection is not better, from what we know, than getting a vaccine. And obviously we know that getting COVID is not good for you. But we also know that if you've had it before and you get a vaccine, your immune system will really respond very vigorously, and you'll have a good immune response. But if it's been 6 months since you've had the vaccine, we do recommend a booster shot, even if you've had sort of both, because you are, again, susceptible to getting sick. And it's not just obviously about you. And, you know, one of the things that I got my booster for, right? It's not just for me. It's just because my dad's older, and, you know, if I can reduce the chance of me bringing it to him and him getting it, that's the other part of the equation.
Okay. What's the math saying right now in terms of kind of breakthrough cases on vaccine? Again, last time we talked, you said that the Department of Health, that it's very hard to distill down breakthrough infections of people who've had it, but you do track generally breakthrough infections of now Omicron for people who are vaccinated, and that, you know, those who are vaccinated can still transmit it, though probably at a substantially diminished rate. Is that kind of the current state of thinking?
Yeah, you know, we are seeing breakthrough infections, and what's been kind of harder to figure out is the number of breakthrough with people who've been boosted, and that's something that we'll be able to show pretty soon. Most of the data we have on breakthrough cases now is really about Delta, because we haven't really had Omicron here long enough to, you know, sort of do those in-depth analysis. Still, you know, the majority of new cases have still been on people who've been unvaccinated, but that's going to go away pretty quickly, because most people are going to, you know, be immune, or they are, you know, more and more people vaccinated. But what we're starting to see, which I think is a little bit not surprising, is we're seeing more and more cases and deaths in older folks who are vaccinated. Part of that's because most older folks have been vaccinated. You know, if you have 100% of older folks vaccinated, 100% of deaths are going to be in people who are vaccinated, right? It's just going to be a lot less. You know, we see, you know, like a 10 to 20-fold reduction in risk of death in older folks who've been vaccinated. So even though we're seeing breakthrough infections and we're seeing some breakthrough deaths, the risk of death is far, far lower for older folks. For older folks, it's really important to talk about getting those boosters, because we know that if you're over 65, your initial response to the vaccine is going to be a lot less robust, just like we see with flu shot, right? And if we think about people who get a flu shot, there is a high dose flu shot, right? That's basically 4 times the amount of antigen or protein in it for the flu shot for people over 65 so they can get a more vigorous immune response.
I want to kind of shift gears a little bit to kind of the federal response. Recently, the CDC came out and changed its guidance down to 5 days, I guess, after exposure if you're asymptomatic. Do you feel like that had really good scientific underpinning? I mean, it's kind of from a public policy perspective, on the middle of the week, the White House was talking about a long winter of death, and all of a sudden said, but you can get out of quarantine in 5 days. And again, it's just kind of one of those things everybody, shakes their head and go, wait a minute, I can't reconcile those things.
Yeah. And there's good scientific rationale, maybe then sort of assurance. And I do know that some of it is the interplay of, making sure that we have folks who can, keep our hospitals open and that sort of thing. If you look at the transmission risk, most of the risk of transmission occurs within the first 3 to 4 days. And most people are at highest risk of transmission before they even know they have it. By the time folks are isolating because of that intrinsic delay, people are way less contagious. And so really, you almost need to isolate people before they even know they have it, because that's where the transmission risk. And when CDC, we talked, and I did have a good conversation with CDC director, that if you really look at the risk, your risk is really almost entirely within that 5-day period. Is there some tail of risk for people who are asymptomatic at point? Probably, but it's really minimal. The amount of virus that they're going to shed is going to be so much lower. And if you really are going to wear a mask, you are really going to reduce that risk. The thing about it that worries me, honestly, is that right now, when I'm out in the community, people aren't wearing masks. And I just can't imagine that folks are going to comply with the 5-day masks after 5 days of isolation. So I think that added benefit that you would get from the mask to sort of compensate for that lower risk of transmission, I just don't know that we're going to see that. We should do it, but I just don't know that folks are going to do it.
Yeah, and we talked in this summer about, and I think you had generally said that at least from a state perspective, that the state had not engaged in trying to enforce mask mandates. And now, certainly through the fall, there's been, a lot of hand wringing publicly and nationally about vaccine mandates. And, and where does the state register any opinion? And obviously, from a political perspective there are, but from a medical perspective, obviously we've been supportive of vaccines. I know you are too. But again, someone who says, well, hey, I had it, 2 months ago, and I feel like I've got, immunity, but if I don't get this vaccination, I'm going to get fired from my job. There seems to be absolutely zero mention of natural immunity anywhere in the CDC guidance, regardless of when you thought you had it. There seems to be like zero room for interpretation or even mention of that in any sort of CDC guidance.
I think it's good for us to look at precedents of how we've dealt with this in the past to give us some idea of what we can do in the future. And I think your point is very well taken. If we look at, say, people who are going to school or even employees of healthcare facilities, we do have mandates for flu vaccine. We have mandates for hepatitis B, mandates for TB skin testing, mandates for MMR for healthcare workers. So those exist already. But also, like you mentioned, prior infection, we do allow people who have evidence of antibodies to measles from natural infection to forego vaccination. So I do think that's an important part of the equation that has been left out of it. I know that people don't have a good sense of what the immune response is going to be long-term compared to the vaccines. Just, they've studied the vaccine so much because it's a controlled population. But I do think that's an important deficit that we haven't put into our conversation.
And then you talk about the federal response. There's kind of increasing rumblings that either from a testing perspective, just the availability of testings that are rationed. I don't think there's vaccine shortages anywhere in terms of to the state, but certainly you mentioned in our last conversation about monoclonal antibody treatment that there now is some shortage, or at least some states are reporting that. I'm assuming that there is greater demand than there is supply for monoclonal antibody treatment here in Mississippi. Is that right?
Yeah, no, you're exactly right. And we have a tricky thing with Omicron in that, we've been very successful in Mississippi, and at least through the Delta surge, we were the most successful per capita in utilizing monoclonal antibodies. There are two products that have been mostly used. One of them is a Regeneron product, and one of them is from Eli Lilly, and they both were effective against the Delta variant. The problem that we have is that the Omicron variant is resistant to both of these products, which previously had been available in pretty significant quantities, although some folks had trouble accessing it as the Delta surge progressed. There is another form of antibody that's effective against Omicron. It's called sotrovimab, but it is available in very small quantities. I think last week we got 126 doses for the whole state. So that's a real challenge. We are, as you can imagine, prioritizing it for those high-risk folks. We're fortunate to have a great network of state partners, what we call the COVID Centers of Excellence, hospitals and health systems that have committed to bring therapeutics testing to the state, not just their patients, but folks in the community, with a focus on disparities and people who are uninsured. We will continue to use those as an outlet for these rare resources. And also for now, we're going to use these locations as a place to distribute the oral antivirals, which are super exciting, especially the Paxlovid or the Pfizer product. But because they're in short supply, we're going to have to get them to places where they can have maximum impact for those who are most vulnerable.
How numerically, how short are we? In other words, what is the relative demand versus the available supply of all of it?
Boy, on a case burden to supply ratio, I mean, we're more than 10 to 1, right, of cases to supply, and it's going to be probably more than that, really. So the demand far outstretches the supply. But in those situations, obviously, it's very important for us to prioritize treatment for those who are most likely to have severe outcomes.
And how's the federal government prioritizing what gets to Mississippi? In other words, or is everybody 10 to 1, or how? I mean, is that how are they figuring out? Okay, how do we ration treatments to different states?
It looks like the oral antivirals, like the molnupiravir and the Paxlovid, those are coming pretty much proportional to population. So that, seems pretty fair. One of the challenges with sotrovimab is they're distributing it based on the amount of Omicron identified in different communities. So we've been under allocated sotrovimab because our Omicron numbers have been delayed compared to other states. And, maybe that is kind of fair, but still, instead of getting 1% of the national supply like we typically do based on population, we've been getting about 0.25% or something like that. So about 3/4 less than what we'd expect based on population.
Okay. Well, you've been generous with your time as always. I certainly kind of leave it for any last thoughts that you have relative to messaging you want to get out there. I appreciate this. This sort of interplay can't happen in a press conference. You just don't get it. So I really do appreciate you doing this. But any last thoughts?
Yeah. So I would just really advise folks to be patient. If we see what's happened in other countries, this Omega surge has really increased rapidly and sort of started to decline pretty quickly. So, if you don't need to go to a party, if you don't need to go out and expose yourself, if you don't need to put yourself in public, for a couple of weeks, it makes a lot of sense. Just kind of enjoy your family at home, do things outdoors when the weather permits. And understand that there are these treatment gaps, these scarcities of treatment right now, but those are going to get better. So, Omicron's not going to last forever. We don't need to disrupt our lives unduly, but for the next couple of weeks, it makes a lot of sense just to be extra careful.
And schools, I know we're coming up on people going back to school the next 48 hours. What is there guidance from the Department of Health relative to that? Or is this just kind of every school district, making their own decisions?
We have sort of unified school safety guidelines that some schools follow pretty strictly and some don't. We will continue to advocate for those, especially now with Omicron. There probably will be some updates around isolation and quarantine based on CDC's updates. So that's going to be the big change. But we still recommend, masking indoors. We recommend spacing. We recommend, isolating and all that sort of thing. So we do have uniform guidance. We're gonna do additional meetings with the school associations to make sure we can get the best information out. But they will be updated to more accurately reflect new guidance on CDC isolation and quarantine.
But from what you see right now today, absent further deterioration of things, the kids should be going back to school here.
Oh, yeah, I think that we're not at a point where people are willing to forego school. Now we're going to see a good number of Omicron cases in school. It's just inevitable. But it's also really important for folks to take the personal initiative. I mean, we're really at a phase of personal initiative. Protect yourself, protect your family, get your kids vaccinated. I mean, I feel really good about the kid vaccine now, having watched millions and millions of kids get it. And we've really seen nothing worrisome. Do what you can to protect your family.
Very good. Well, Dr. Thomas Dobbs, we appreciate your time as always. Certainly encourage you, readers of Y'all Politics, to catch up with us on our social media channels on Facebook and Twitter. And again, thank you for your service to the state of Mississippi, and we hope everybody has a blessed day.
Yeah, thank you. Thanks for having me.